Hello, and welcome to our presentation today, Guided by Flow, Stroke Volume Directed Therapy Reduces Mortality in Sepsis. My name is Lisa Soltis, and I'm one of your presenters. I currently work as a Senior Clinical Support Specialist for the Novolung Heart and Lung System. I live in Raleigh, North Carolina. My disclosures then that I am a speaker and consultant with Baxter Healthcare. I also have an educational and legal consulting company of my own, as well as I still work per diem at WakeMed Health and Hospitals in the CTICU.
And my name is Angela Craig, and I'm a senior manager for medical affairs here at Baxter Medical. And as far as my other disclosures, I still work for Cookeville Regional Medical Center in Cookeville, Tennessee, as a clinical nurse specialist PRN. I am an independent consultant, just rarely, don't have a lot of time for that. And as far as non financial, I am on the Sepsis Alliance Advisory Board.
Thanks, Angela. So our objectives today are to review recent literature related to mortality in septic patients, discuss how to conduct dynamic assessments for fluid to assess for fluid responsiveness, and also discuss stroke volume guided therapy and alternative settings outside of the ICU, such as rapid response, emergency department, as well as the operating room. So to address our first objective, to review recent literature related to mortality in sepsis. So to discuss mortality in sepsis, where are we currently? We know that sepsis affects over 1.7 million Americans each year, as well as having an age standardized incidence rate of 677 people per 100,000 people worldwide. So globally is still impacted by sepsis. And some of the areas in sub-Saharan Africa and other areas in Asia, they may have some of the highest rates of that incidence. Mortality rates can also vary between 15 to 25% in high income countries, whereas septic shock mortality may reach levels as high as 30 to 40%. When we look at what we know, we've done years of research and clinical data collection to see what works and how can we make a difference to impact those mortality rates. Using that bundled approach, following the Surviving Sepsis campaign and the Surviving Sepsis guidelines. We know the basics, early recognition, early and appropriate antibiotics, source control, fluid resuscitation, vasopressors, lactate monitoring. The bottom line is perfusion and organ support and following the SEP1 bundle. Our focus today is to talk about the literature that helped get us to where we are now, and then to specifically look at dynamic assessments and fluid responsiveness assessments to determine how do we best manage fluids and help improve patient outcomes with that. So what have we learned over the years? We know that, in 2001, Manny Rivers really changed the landscape of how to manage patients with sepsis. We had the mindset of, more is better. We can always get it off later. But he really set that landscape as far as improving clinical outcomes to reduce mortality rates with patients with sepsis. Fluid administration was guided by CVP as well as SVO2 in that study. And so that was one of the first studies that really looked at we need to be more aggressive with our fluid resuscitation measures with that. And that's what set the stage for us. In 2006, Vincent brings the results from the SOAP trial and also identified that having a significant positive fluid balance was one of the strongest prognosticators for predicting death with that. In 2011, Boyd and the VAST trial showed that a positive fluid balance also had a higher indication or higher likelihood of mortality with that, especially in the first 4 days cumulative, increasing that risk. When we get to 2015, then Kelm looked at early goal-directed therapy as well as the positive fluid balance. And again, all of these indicators started looking at developing increased mortality with those higher fluid volumes. And so one of the things that, we realize, hindsight is always 2020 is looking back is that we focused so much on CVP and fluid, and we really didn't look at what are the other aspects of making sure patients survive. And the biggest part of that was organ perfusion and overall perfusion and oxygen delivery to all of the tissues. And so it's not just fluid, but we need to look at all of the perfusion components of it, as far as not just preload, but also our afterload, our, basically our systemic vascular resistance and our contractility of the heart, to make sure that we could improve those. So we were, trying to figure out, how do we fine tune this? And that's when we really started to look at, okay, maybe too much fluid is not an attitude to say, well, we can always get it off later. In 2017, then Paul Merrick, in his work, was able to identify that, a positive fluid balance, especially in the first few days after that diagnosis of sepsis, or meeting those sepsis criteria, was an independent predictor of increased mortality. And that's when we really started to look at, okay, how can we do this differently? The roots of our present day sepsis management, as far as the sepsis guidelines and our SEP1 bundles, are all still rooted in that initial work that was done by Dr. Rivers back in 2001. And we've continued to grow with that. And now, as we look to fine tune that, how can we best serve our patients by looking at making sure we're giving the right amount of fluid to each patient, and that we don't take a one-size-fits-all approach. So this diagram, I'm sure many of you may have seen this before. It's called the Bellamy curve, and it's basically looking at our fluid administration compared to the potential complications associated with it. And so in this particular curve, we want to be in the middle. We want the fluid volume to be optimized for each patient, and we know that we can have complications if we have too little fluid that's being administered, as far as hypoperfusion, hypotension, leading to, overall organ failure or insufficient organ oxygenation, and that can lead to multi-organ failure. The other side of that curve then is that if we give too much fluid and now they're hypervolemic, then that leads to, overall tissue edema, organ failure, increased need for mechanical ventilation, and damage to the lungs, increased ventilator days, and also increased mortality. So the things that we need to take away from that is realizing that, with sepsis and shock, that, fluid overload is independently an increased risk of mortality. And then we've also learned then, through additional studies in surgery and looking at the ERAS protocols and the early recovery after surgery, that careful management of intraoperative fluids then can also help enhance patient outcomes. So the overall goal is realizing, we need to take an individualized approach to this and not swing it too far one way or the other. So looking at the literature and the data behind that Bellamy curve, early on, when we looked at, too much fluid, it started with, Dr. Rivers in 2001, and using just the CVP to guide our fluid management with that. The process trial, ARISE, PROMISE, all tried to basically, repeat the outcomes that we're seeing with the early goal-directed therapy trial that Dr. Rivers had done with that. So again, they were looking at protocolized approaches to see, is a liberal approach versus a, restricted approach better, looking at vasopressors versus not, other types of things. And none of them were able to actually repeat those same type of advancements as far as improving outcomes with that. Some of the challenges is that we knew fluid resuscitation is a critical aspect of these patients when they're diagnosed with sepsis, especially early on. And so if, we don't give them fluids, then ethically that would be inappropriate, because we know that that can be a life-saving measure. And so as those trials and those studies themselves tried to duplicate those efforts, they had to basically, they gave each group, both the control group and the intervention group, each got between 2 and 3 liters of fluid to start with before they were randomized to either arm of those trials. And so there really wasn't a significant improvement in either group. And part of it was because of the design of the trial, and it kind of leveled the playing field. And so it made it very difficult to kind of determine, well, how do we further advance our outcomes for these patients? When we go to the other side, with, Vincent and Boyd, Kelm, and Merrick all show that too much fluid definitely increases mortality. So we need to be careful on how we do that. And we need to be able to guide that to individually meet the needs of each patient with that. It's not until in the last few years, as far as Latham was one of the first studies in 2017, Ivor Douglas in 2020, and the premier abstract, we'll talk about those studies in a few slides, but those were actually looking at stroke volume guided care, dynamic assessments, and they were actually able to demonstrate significant improvements in patient outcomes, need for mechanical ventilation, and things of that nature. And so we'll be talking about those in more detail as we continue on. All right, so this is one slide I love to talk about because, when we ask people, how do you know if somebody is, if they're perfusing, and how do we look at, determining whether or not somebody isn't, getting adequate oxygenation? And so, when you ask, well, what do you look for? And so many people will say, the mean arterial pressure, I look at the heart rate, I look at their urine output, and those are really late indicators of changes in hemodynamics and changes in perfusion to the organs themselves. So this is actually a study that was published in the Lancet in 1944. And it was a study where they had 7 male subjects that volunteered to be part of the study. And when you look at the graph on the side of this, on the side of the slide there, when you look at, you've got your TPR, which is your total peripheral resistance. So basically your afterload and your vascular tone, your heart rate, your blood pressure. Then down at the bottom, RAP is your right atrial pressures, and then your cardiac output are listed there. So in the study, they basically did a venous section and allowed, they collected the blood, but basically allowed the patients to bleed, or the subjects to bleed. And as the blood volume, started to, wane, and they started to lose blood volume, one of the things they noticed is as soon as they started draining blood, that the right atrial pressure immediately dropped and the cardiac output immediately dropped. Looking at the heart rate in our compensatory mechanisms, and we saw the heart rate immediately increase, and the blood pressure, dropped a little bit, but it maintained pretty well. And it wasn't until they got to the point where they had lost so much volume that they actually passed out. And that's when we saw the blood pressure completely drop, and the heart rate drop, and their total peripheral resistance drop. To match what was actually going on internally. So we know that blood pressure can be maintained because of those compensatory mechanisms. And heart rate, that variability isn't a adequate predictor either. And so cardiac output, which kind of drives our stroke volume guided care and that type of monitoring, really is the earliest indicator that the patients are in trouble. And so we need to look at a better way of monitoring our patients' perfusion. We know that with traditional monitoring, if somebody is losing volume, early on, based on those compensatory mechanisms, the cardiac output will start to drop very early, but the MAP will maintain relatively normal until they've lost almost 25 to 30% of their circulating volume before you see a change in MAP. So again, it's important to look at other ways of monitoring perfusion other than just a static measure like CVP or mean arterial pressure. So with that, we're going to move into our next objective, and I'm going to have Angela take over from here.
So we are going to discuss how to conduct dynamic assessments for fluid responsiveness. So in the 2021 Surviving Sepsis Campaign recommendations, it mentions for adults with sepsis or septic shock, we suggest using dynamic measures to guide fluid resuscitation over physical examination or static parameters alone. And so really encouraging us to use a stroke volume measure. So, why dynamic measures? Well, in this particular study, will this hemodynamically unstable patient respond to a bolus of intravenous fluid? We find that only 50% of patients are fluid responsive. And you can see here that that's 1 out of 2, right? So when we have patients who are hypotensive, and many times we just think, okay, let's give fluid, we don't really know if their heart is able to take and receive that volume to help forward flow to improve perfusion. Next slide. We know then that only 50% of the patients may benefit from additional fluid resuscitation. 50% of the patients won't benefit from additional fluid resuscitation. And so, what do we need to do to find out how a patient can respond to fluids? When you look at, if you would click it one more time, if you look at here, you can notice that when you see the response to passive leg raising, that has the highest sensitivity and specificity. And I think you can click one more time and it will show specifically with the changes in cardiac output and in controlled ventilation and spontaneous breathing. So, the best choice we could do in order to determine if our patients are fluid responsive, if they are going to take that volume that they receive and have forward flow to improve perfusion, the highest sensitivity and specificity is with the passive leg raise. So, how do we do this? Well, there's 2 ways of doing it. So, I'm going to start, since I've talked about passive leg raise, I'm going to first talk about how we do that. So, notice on your screen on the left side, it shows a picture of a PLR. So, we try to get that patient's head of the bed up as high as possible, 45 degrees, it should be the minimum, to pull that volume away from their heart. And so, it's going to be more in the lower extremities. And after, we want to get a baseline then with the patient's head of the bed up as high as possible. And then after baseline, then we'll go ahead and lay the patient flat and we'll passively lift their legs. So the patient should not be helping us. Passively lift the legs, and that volume will go back to the heart and test that heart to see if they can take and receive that volume to help forward flow to improve perfusion. Now, how do we determine if they can do that? If they have a 10% or greater increase in stroke volume. So that is what they're looking at: stroke volume index, basically having a 10% increase or greater. Now, we can do this one other way, because let's say maybe somebody doesn't have a lower extremity. So we might need to do a fluid bolus. So you can test the heart with a fluid bolus as well, but it's a little different. Obviously, you would have a 3-minute baseline once again. And by the way, during that baseline, your patient can be in any position, but we just recommend during the baseline not to be moved. The patient shouldn't be moving a lot. And then we can start the volume. Oh, and by the way, I should mention that we are connected to a non-invasive hemodynamic monitor, right? In both of these scenarios. And it's going to calculate your stroke volume for you and those changes in stroke volume. So we're going to do a baseline with a bolus. We're then going to challenge the heart. And by the way, this is done the good old fashioned way with a fluid bolus, not 999 on the pump, but 250 in less than 5 minutes, or 5 minutes or less, 500 in 10 minutes or less. Okay. So basically putting it on a pressure bag, squeezing that in while the monitor is monitoring so that we can see if there is an increase in stroke volume. The only real reason to give a fluid bolus is to increase cardiac output, which will increase stroke volume, right? Next slide. So when you think about the passive leg raise, I just want to kind of show you this slide as well. We already talked about it, but this is kind of showing you how this will work with the head of the bed up first. And then when we lay the patient, you can go ahead and click it. And you can see the volume from the lower extremity goes back to the heart. And you can click it one more time, and you can see that the legs are elevated for 1 to 2 minutes. And it does require a stroke volume measure. Next slide. Now, when I mentioned how accurate this was, this is another meta-analysis of passive leg raises, and it shows 23 clinical trials where the PLR was used with cardiac output and stroke volume measured to predict fluid responsiveness. That area under the curve was very high, like 95% accuracy. So very excellent, and is an easy test to really, you can train nurses, doctors, residents, even techs can do a passive leg raise. It's not difficult. Next slide. Now, this is another study that talked about incorporating dynamic assessments of fluid responsiveness into goal directed therapy, and it was a meta analysis. Next slide. And basically, what it showed was that in adult patients admitted to the intensive care who required acute volume resuscitation, goal directed therapy guided by assessment of fluid responsiveness appears to be associated with reduced mortality. And that is really what this talk is about, showing you that utilizing stroke volume guided care can help reduce mortality. Also, decreases ICU length of stay and duration of mechanical ventilation. High quality clinical trials in both medical and surgical ICU populations are warranted to inform routine care. So I just think many times we sometimes have non invasive hemodynamic monitors like in the closet, right? I say get them out and utilize them to help you determine if a patient and know if your patient can take and receive this volume to help perfusion. Next slide. So, what is fluid responsiveness and how do we treat? Well, we talked about fluid responsiveness being an increase in stroke volume or stroke volume index by greater than or equal to 10%, right? In response to volume. Now, if the patient has greater than or equal to 10% change in stroke volume index with a passive leg raise or a fluid bolus, as we've mentioned, they're fluid responsive. So additional fluid could be a good choice to improve perfusion. We would obviously use this data along with patient assessment, and we would give fluid to improve perfusion. Now, if the patient didn't have a 10% increase in stroke volume related to a passive leg raise or a fluid bolus, they are not fluid responsive. And additional fluid is unlikely to help improve perfusion. So we would then look at contractility. We would look at afterload, some of those things that Lisa already mentioned, to see if a patient needs maybe vasopressor therapy or inotropic therapy. And one other thing I think is important to mention is just because somebody is fluid responsive does not mean they need fluid. But I would also venture to say that most patients that you have on a non invasive hemodynamic monitor are probably on it for a reason. They're probably either hypoperfused or hypotensive. So, in those patients, when they are fluid responsive, fluid may very well be a good choice for the patient to improve perfusion. Next slide.
Okay, so I'm going to pick up from here. So we're going to talk about the mortality benefit of incorporating that stroke volume guided care, and we're going to start in the ICU. So I had mentioned earlier about the study with Latham in 2017. So this group looked at Kansas University, or you'll hear it referred to as the KU trial, and they used stroke volume guided resuscitation in severe septic and septic shock to help improve outcomes. And so looking at the net fluid balance on that graph there on the side, the dark blue then is basically the stroke volume guided care. And then the light blue was the usual care group. And so basically they had 100 patients that were in the stroke volume guided care, and we had 91 in the usual care. It was a retrospective cohort study, and their goal was to find that happy middle as far as optimizing fluid volume resuscitation for each patient. And so basically, generating this hypothesis. What they found then, there was a reduced fluid balance in the stroke volume guided care. So those that received stroke volume guided care, 1.77 liters average compared to 5.36 liters in the usual care. Reduced ICU length of stay by 2.89 days, less vasopressor use by almost 33 hours, less mechanical ventilation by 0.51% with that, less dialysis, so 6.25% compared to 19.5%. And as what we've discussed, 53% of those patients that were in that cohort were fluid responsive. So it holds true to that, 50% will be responsive, 50% most likely are not. So then figuring out how do you optimize that care. So this was one of the first studies that really looked at using a stroke volume guided measure. So when we look at stroke volume guided care, then in both the emergency room and the ICU, this was the FRESH trial. This was with Dr. Ivor Douglas in Denver Health, and it was the fluid responsive evaluation in sepsis and hypotension and shock. So in this study, they basically looked at the patients as they, came in, in the emergency room as well as in the ICUs to determine. So the question that they we're looking at is, are they hypotensive or hypoperfused? And so this is just a picture of what their protocol actually looked at using a passive leg fluid responsiveness assessment while utilizing a non-invasive bioreactance assessment to determine their stroke volume change. So the endpoints in this study, then, the fluid balance at 72 hours or at ICU discharge. The treatment group was anywhere between 0.65 plus or minus 2.85 liters, and the control group was actually 2 liters positive plus or minus 3.4. So there was a significant difference in the amount of fluid administered in those groups. The need for renal replacement therapy in the control group was only 5% compared to the control group, or the treatment group was 5%, the control group was 17.5%. The need for mechanical ventilation was decreased by half, so 17% in the treatment group versus 34%. The ICU length of stay was also decreased by almost half, so 3.3 days compared to 6.2. And then discharge home, which is another very important metric because it doesn't mean that they're discharged to another acute care facility, long-term acute care facility, rehab, where they need extended care or extended services with that. The treatment group, 63.9% were able to go home compared to the usual care group, which was 43.9%. So again, you saw a significant improvement in their quality of life after leaving the hospital. This study was actually, this abstract was presented at the Society of Critical Care Medicine this year in February of 2025. And so it was a retrospective cohort looking at the Premier Healthcare Database, which contains over 612 hospitals. Inclusion criteria were ICU admitted septic patients, so that gave us an N of over 190,000 patients. Exclusion were hospitals that had less than 300 cases or they had a greater than 10% transfer rate. So they were looking for more of the hospitals that they actually kept the septic patients and managed them there. The use of non-invasive bioreactants was identified using hospital charge codes, and there were 3 hospitals that were included that had greater than 10% NICOM use, or non-invasive cardiac output monitor, that were included. The measured outcomes were related to 3-day and hospital mortality, ICU and hospital length of stay, and the total cost. And then they also used risk-adjusted models on patient demographics, comorbidities, and acute organ dysfunction. So results in looking at this data, there was a significant reduction in the 3-day mortality. So it decreased by 3.4%. Hospital mortality decreased by 4.7%. ICU length of stay also decreased, as well as their overall hospital length of stay. And bioreactance was used in 17% of those patients. So again, looking at these metrics, having a decreased ICU length of stay, decreased hospital length of stay, the mean hospital cost was also reduced as well. So that particular abstract, they're in the process of writing a manuscript to expand on that. But some of the strengths related to this, review of that data and the Premier data, help database, the Premier Health database. Some of the strengths, it's a very large, diverse data set with over 190,000 patients that were included in this particular study from 2016 to 2019. It gives us real world clinical practice insights, beyond just the controlled components of it. Identified bioreactance use with hospital charges, so it's easy to identify which patients were part of that cohort. Also allowed us for risk adjustment as far as present on admission and other comorbidities with that. Enables cost and resource utilization analysis, as well as supports multi-center comparisons across a variety of hospital types. Some of the weaknesses, there was no direct measurements or any actual values that were captured as far as the percent of fluid responsiveness or actual cardiac output that was captured. So it lacks that granular hemodynamic data as far as monitoring stroke volume trends with that. There is the potential for confounding by indication as far as the practice levels across some of the hospitals, and charge codes may not actually fully capture what was the actual use of the bioreactance technology with that. So looking at stroke volume guided therapy in alternative settings, such as rapid response, the emergency department, and in the operating room. So what types of studies have we seen there? So the mortality benefits with rapid response. So this study by Rossiter was published in 2024 in the Intensive Critical Care Nurse, the use of bioreactants in a rapid response assessment. And so basically using a nurse-based protocol to assess fluid responsiveness in patients that required, what we would consider in the US a rapid response or a clinical support of patients outside of critical care. You can see there the cohort description is there, as well as what their protocol looked like. And in this particular case, they utilized a bolus application to assess stroke volume changes versus using a passive leg raise. And so things of note between the pre-intervention group and the intervention group. On the left-hand side is actually the pre-intervention, and the right-hand side is the intervention group. And so there was a significant difference in the number of patients that had shock and the percentage of shock clinical components that were seen with that as far as signs and symptoms related to that. So overall, this group was a little bit sicker than the pre-intervention group with that. There was also a difference in their mean arterial pressure from the pre-intervention group to the intervention group. And so again, supporting that the intervention group actually had a little bit sicker patients compared to the pre-intervention, as their systolic pressure and their MAPS were both lower than the pre-group. So what did they find with that? And so what type of outcomes were seen with that? So one of the more important aspects of that is we know if people get over resuscitated, it can lead to, edema of the tissues, especially the lungs. And we know that it's a significant burden when patients require mechanical ventilation and other types of support therapies as far as renal replacement therapy and other types of resource heavy treatments to manage them. So one of the first things noted was the number of patients that required renal replacement therapy. In the pre-intervention group, almost 21% of those patients required renal replacement therapy compared to none in the intervention group. When we looked at the number of patients that required mechanical ventilatory support, about 21% in the pre-intervention group to none in the intervention group. The number of patients that required BiPAP or CPAP, so positive pressure airway support, not necessarily intubated, 31% in the pre-intervention group and 0 in the post-intervention group. Other things also then looking at the days until discharge. So the median in the pre-intervention group was 7 days compared to the post-intervention group, which also indicates that these patients were definitely sicker and they had fewer resources that were required, but they definitely had a significant impact to their ability to get out of the hospital. And so it was a sicker group, but they required less invasive therapies to help get them through that rapid response. So one of the things of note of this particular study also is that, it wasn't a randomly controlled trial. It was basically looking at, what their previous practice and then what it looked like after they, uh, basically instituted this new protocol for their rapid response group and having this nurse-based response team with that. So it was not weighted enough also to determine causality. So that's an important aspect to keep in mind, because when we look at survival of those patients, looking at our pre versus post, there really wasn't a significant difference in survival between the two groups. But part of it is because of the way it was reported. So they actually reported an absolute reduction, which is just an actual, plus and minus. What was the actual difference between the two groups that were analyzed with that? Most studies will do a relative reduction. So it's basically the percentage of change compared to one group to the other. And so in this particular group, they just did an absolute reduction and they didn't really look at it as a relative reduction. We also know there was variability between the two groups because the second group was definitely more acutely ill and had a significantly increased use of vasopressors in those particular patients. But there was a significant reduction in the need for renal replacement therapy, a reduction in mechanical ventilation and BiPAP. And so that also mirrored the same type of outcomes that we saw with the case study, with the FRESH study, as well as the Premier Healthcare database as well. So implications for practice then is, understanding that adoption of dynamic measures of cardiac output and stroke volume outside of the ICU is also feasible and easily implemented when you have a team that's been trained to do that and be able to translate to improved outcomes outside of just the ICU. Using that non-invasive bioreactance monitoring can provide an easy dynamic assessment of fluid responsiveness and allows a personalized approach to fluid resuscitation and fluid therapy for patients. And then the last one is looking at stroke volume guided care in the operating room. And so this Messina trial was looking at perioperative outcomes with goal-directed therapy. It was a meta-analysis of 21 randomly controlled trials with over 2,700 patients, looking at goal-directed therapy versus the control. And so they saw that when they used a goal-directed therapy approach and individualized the fluid resuscitation approach, the postoperative complications were significantly reduced and the mortality was reduced with a high-risk population. So those were all very positive outcomes with that. The Fedora trial then was looking at 450 patients undergoing a abdominal surgery. And these were patients that were in the ASA 1 to 3 category. So these were not sick patients. These were, relatively healthy patients that came in. It was a European prospective multi-center randomized study looking at goal-directed therapy versus just the standard of care. And what they found in this low risk or, low risk group of surgical patients that many times we would think, well, we don't really need to monitor them because they don't have a lot of, confounding factors or risk factors that would put them at high risk of having complications during surgery. But by monitoring and doing, again, an individualized stroke volume guided care for those patients, they saw, even with a relatively healthy group, a significant reduction in kidney failure, pulmonary issues, heart failure, surgical infections, length of stay, and early mobility and oral feeding with that. And so again, the length of stay was reduced in the goal-directed therapy, and the length of stay in ICU was significantly reduced. So indicating that even patients where we think, well, they're not that much of a risk, so do we really need to monitor them in the operating room? And actually, it was clearly shown that even low risk patients benefited from a goal-directed therapy approach. So that's something that we should consider as well moving forward. All right, so now I'm going to turn it over to Angela in our case study.
So hopefully you've enjoyed that nice review of lots of pieces of literature that really show that we can decrease mortality or help with some of these outcomes to better outcomes, lower opportunities for patients to be on RRT, as well as lower opportunities for patients to have to be on the ventilator. And so really have shown you a lot of good data. So I'm going to take you through a case study and show you how you can utilize this stroke volume guided care to help individualize treatment. So I'm going to start with the three levers of perfusion and go over those just briefly because I think it's so important to make sure we're all on the same page. It's all about perfusion, right? It's not necessarily about pressure. Pressure does not equate to flow. Next, click. So blood pressure is just that. It is pressure, right? And cardiac output is heart rate times stroke volume, and that's more of our flow parameter. And so we want to talk about the first lever, preload. So when we're thinking about preload, we're going to do a dynamic assessment, and we're looking at stroke volume and stroke volume index. And you can go ahead and click it. And you're going to think V for volume, and normal stroke volume is 60 to 100. So I think if you can just remember normal heart rate, that's going to help you. And know this, that if you have a patient with a low stroke volume and they are hypotensive, or you're feeling like they may be hypoperfused, or it's a patient that you may need to give fluid to and has heart failure or renal failure, you're just nervous about it, you can perform a dynamic assessment to see if they are fluid responsive, right? So that's your first lever. The second lever, and you can just go ahead and click through it, is afterload. So TPR or TPRI. I think of TPR as the non-invasive, almost equivalent to SVR, right? It's that resistance. Think R for resistance. Normal TPR is 800 to 1200. And the lower that number, the more vasodilated is how we think of this. The higher the number, the more vasoconstricted. So in that one study that Lisa was sharing with us, as the patient bled, how they were clamping down, right? Normal compensatory measures has us clamp down. So you saw that TPR shoot right up, or the SVR shoot up, and then eventually cardiac output starts to decrease, right? So the lower the number, the more vasodilated, the higher the number, the more vasoconstricted. And then our third lever is contractility. Think cardiac output, cardiac index, normal cardiac output 4 to 8, normal cardiac index 2.5 to 4, and you think C for contractility. Now, it's important if it's low to ask why. If that cardiac output, cardiac index is low, why is that low? Because it could be that maybe somebody needs fluid. Hopefully, we will have assessed that preload responsiveness to determine if they did need fluid or if their heart could accept and receive the fluid. But it may be that it's low because the patient has a poor pump, right? What is that patient's ejection fraction? That's another question I frequently ask when I think about contractility. And what is their cardiac output and index? And do they potentially need a positive inotrope? So these are the three levers, and we're going to look at those levers as we do the completion of this case study. So we have a 70-year-old female who comes into the emergency department with a cough and has had this cough for 5 days, associated also a fever. And patient states she took a home COVID test and it was negative. She tested negative for the flu and the COVID test in the emergency department, but her chest x-ray did come back as a bibasilar pneumonia. Patient was started on the sepsis bundle and connected to the non-invasive hemodynamic monitoring in the emergency room so that the fluid could be individualized to meet her needs. So she had a diagnosis of bibasilar pneumonia. Patient did receive a lactate and blood cultures in the emergency room, was given a liter of fluid in the ED, and also antibiotics were given in the emergency room as well. And you can see the patient info over there on the right. Temperature's elevated. Blood pressure is low with a MAP of 53. Heart rate is elevated at 125. White count elevated at 22,000. Lactate elevated at 6. BUN is 30, creatinine's elevated at 2.2, and the procalcitonin is elevated at 4. So I think it's important when you have the patient connected to do that really quick down and dirty assessment with the three levers, right? First question we're asking, is our patient hypotensive or hypoperfused? Well, we knew they were hypotensive. Now let's look at stroke volume, thinking about preload. Stroke volume's only 45, right? So stroke volume is low. We look then at TPR at our afterload assessment, and it looks like it's low. Normal is 800 to 1200. So it is low. So we think of our patient as more dilated, and the cardiac index is 2.7, cardiac output 5.6. So from a contractility standpoint, that looks pretty good. So since our patient is hypotensive, we are going to do either a passive leg raise, next slide, or we are going to do a fluid bolus. Next slide. So we do a passive leg raise and we get a 4.4% increase in stroke volume. Question, is this patient fluid responsive? Answer, no, right? Because they're not 10% or greater with their stroke volume change. Now, next slide. Based on our clinical findings, what do you think we should consider next? Now, I want to take just a moment for you to pause and think about which answer you would give. Okay, go ahead and click. Hopefully, many of you selected vasopressor. And when we think about this, we have a patient who is hypotensive. They are not fluid responsive, so we don't want to give fluid, right? Their stroke volume is low, but they're also dilated and probably need to be tightened up a bit, right? We're not going to give more IV fluid, and we're definitely not giving a vasodilator as this patient is already pretty dilated and already has a low blood pressure. Next slide. So norepinephrine was started and we increased it over the next hour. Let's just say, no matter where you're at, which institution you work at, that we maxed it out in an hour. Okay. So here's our numbers after it's been maxed out. Temperature came down, but that was because we gave some Tylenol. Heart rate, you can see, is still elevated, but it's better. Mean arterial pressure is better. We're up to 60, but we're still not where we want to be, right? Our goal should be a 65 mean arterial pressure for this patient population. Stroke volume is low at 49. TPR is up to 831. Now, I wonder why our TPR has increased. Well, let's think about this. What did we start? We started a vasopressor, right? So what I like about this is that we can get some feedback very quickly, some affirmation that, hey, it looks like we're going in the right direction. And so you can see that it's tightening that patient up a bit. And then the cardiac index is 2.5 and the cardiac output 5.2. Next slide. So our question now is, based on this information, is the patient hypotensive or hypoperfused? Well, this isn't a quick trick question. And many people might say, oh, well, they're so close. Their MAP is 60. But the reality is their MAP is too low to perfuse all their organs, or based on our guidelines that say these patients should have at least a 65 MAP. So yes, this patient is hypotensive or hypoperfused. So they deserve to have another assessment to determine what should our next intervention be. And by the way, I just want to mention that it's not just one or done. It is that if our patient has a change, we can do another passive leg raise. No harm, no foul. If they are not doing well with a passive leg raise, lift their head up. It's reversible. Lower their legs, right? And the volume goes back to their lower extremities. But in this case, we're doing another passive leg raise. Next slide. And we find that this patient is now 6.1% increase in stroke volume. So is this patient volume responsive? Hopefully, you're saying a resounding no, because they are not, right? It's only 6.1%. So this patient is not fluid responsive. Next slide. So what should we think next would be our next step? Based on our clinical findings, what should we consider next? And I'm going to pause just for a moment to let you have some time to think. Are we going to increase the norepinephrine? Are we going to add vasopressin? Are we going to add a positive inotrope? Are we going to give more IV fluid? Or are we going to give a vasodilator? And I hope you all chose Add another vasopressor. So we're going to give vasopressin, and this is kind of pretty much a guideline from Surviving Sepsis Campaign guidelines. Pretty much that is what they are suggesting we do. If we cannot maintain their blood pressure, then we would add another pressor. And vasopressin is the vasopressor of choice here for the secondary one. Next slide. All right, so now we have norepinephrine going and we have vasopressin going. Next slide. And the pressors continued. Blood pressure did improve for the next hour. MAP was greater than 65. TPR increased as well. Lactate decreased. So we feel like we're going in the right direction. But after about an hour, all of a sudden we notice the stroke volume decreasing and the cardiac index drop. So let's look at our numbers together. Temperature looks better at 99.9. Heart rate is still a little tacky. The patient's still a little tacky. Pressure looks good. And I recommend if you just saw a patient with a 99.9, heart rate of 110, and blood pressure with a MAP of 66, you'd probably be like, let's just stop there, right? They're at least stable. But really, this patient is far from stable. If you look down at the lower three, if we did not have this patient connected to a hemodynamic monitor, we would miss out on some very important key concepts. This patient's stroke volume is down to 35. This patient's TPR is up to 1231. We are really constricting this patient now in efforts to bring up that mean arterial pressure. We all are well intentioned, but notice what that constriction has done to the cardiac index. It is making it very difficult for the patient's heart to pump against that resistance, and that cardiac index has decreased. And we're at a very low level here. We should be very concerned for cardiogenic shock and very concerned that and need to probably have an intervention here fairly quickly. I just want to remind you that as we add pressors and more pressors, there are consequences to that. And it many times in the sepsis patient, a high percentage of patients end up with this cardiovascular decline. And so they're not able to pump as effectively. And many of them show decreases in ejection fraction even. So I want you to be aware of that. Next slide. So let's ask the question, is this patient hypotensive? Well, technically, no. We have a MAP of 66, but are we hypoperfused? Hopefully, I know I only just have a few variables. I don't have the whole clinical picture, but notice that cardiac index being less than 2, we're definitely hypoperfused. Next slide. So we're going to do another passive leg raise just to see if this patient is volume responsive. Remember, I said when somebody has a low stroke volume as well as when they have a low cardiac output or index, we want to know, would volume potentially help? Next slide. So we only had 8.6% increase in stroke volume. So that is not fluid responsive. So next slide. Based on these clinical findings, what should we consider next? Now, I'm going to pause and read the answers, and you just think, what do you think, based on these numbers you're seeing, would be best for this patient? Do we want to increase the norepinephrine? Do we want to? We've already added vasopressin, so I probably shouldn't have given that as an option. Do we want to give a positive inotrope, something like dobutamine? Do we want to give more IV fluids? Or do we want to give a vasodilator? So I'm going to pause and let you think about this. And hopefully you all chose a positive inotrope. Now, we don't want to necessarily increase the norepinephrine, first of all, because we have a patient who has a normal mean arterial pressure, right? But also because this patient is already very vasoconstricted. So if we don't have to increase, we don't want to. We're already on vasopressin. We're not going to give fluids because we're not 10% or greater fluid responsive, right? And we're not going to give a vasodilator. So we are going to start at dobutamine or a positive inotrope. Next slide. Now let's look here as we now have norepinephrine, vasopressin, and dobutamine, all three. Cardiac index improved as well as an increase in stroke volume. Next slide. 3 hours after dobutamine was started, the blood pressure dropped. Notice we have a mean arterial pressure that was 61, but even before the blood pressure dropped, we saw a trend down in stroke volume. So it went from 50 down to 42. And by the way, I always say trend is your friend. If you don't have to remove the monitor off a patient to use it for somebody else, try to keep it on there because you will see that trend down in stroke volume well before you'll see a change in blood pressure. And we're on three drugs right now, right? Norepinephrine, vasopressin, and dobutamine. All right, next slide. Question: is this patient hypotensive or hypoperfused? Well, yes, we're down to 61 mean arterial pressure. Next slide. So let's do a passive leg raise, right? Let's just see if now that we're on all those different medications, will there be something else we can do for this patient? Next slide. And lo and behold, we are now fluid responsive. 14.3% increase in stroke volume. Next slide. So, what would you like to do? And this should really be a no brainer. I'm not going to belabor this. This patient is still hypotensive. So, and they're fluid responsive. So, let's give some fluid, right? So, we're going to give some balanced solutions. Next slide. And the patient was given the bolus based on stroke volume response. You can see that that stroke volume after 500 mils was given, it went up to 52. And since the stroke volume was still low at 52, another fluid responsive assessment was done to see if the patient would just respond, to see if we could improve that stroke volume. And lo and behold, it did. So you can see that the stroke volume went up to 62. You can see the mean arterial pressure was up to 73. Our TPR looks better. And you can see that that cardiac output and cardiac index is better as well. So what would we like to do here? We are going to hold tight and down titrate, right? We don't want these patients to be on these drugs for any more time than they need. And maybe since we've kind of worked on tone and a variety of things, hopefully with the appropriate amount of fluid now, hopefully we can easily down titrate. Next slide. We have many references from this presentation. And next slide. You are welcome to look up any of those. I do want to mention that we also have a medical education website, and it's called fluidmanagementeducation.com. You can see the QR code here, but you can watch education videos. You can listen to the DRIP podcast that we have, review the latest studies and literature, a variety of things. If you sign up, you will get some fast fluid facts that will come to your inbox about weekly for about 20 weeks or so, and they'll be sent straight to your email. We really hope that you can sign up or really find this helpful for you in your daily practice. Next slide. And now we would just like to mention that our email addresses are here: Angela_Craig@Baxter.com, Lisa.Soltis@Yahoo.com. If we can ever help or be of assistance, please don't hesitate to reach out to our email, and hopefully we can answer any questions you have about this presentation. Any last
Absolutely.
words, Lisa?
Just thank you for joining us and continuing to learn and figure out how we can best manage our patients and give them the best outcomes possible. Thank you for joining us.
Yes, we just want to thank you.